Before I begin, I would like to thank the United States Department of State, the Fulbright Scholars Program, and the U.S. Embassy in Kingston, Jamaica, along with the University of Rochester School of Nursing and the Center for AIDS Research for funding this project. The completion of this project was made possible with committed and continued faculty support from Doctors Jane Tuttle, Craig Sellers, Ann Dozier, and from all faculties from the School of Nursing in Rochester, and of course Dr. Leif Dunn, who's a senior lecturer in the University of the West Indies in Jamaica. According to data released in 2011 by the Statistical Institute of Jamaica and the Ministry of Health, the island of Jamaica consists of approximately 2.7 million people, with an annual growth rate of about 0.7%. and an adult HIV prevalence rate of 1.8%. Additionally, both UNAIDS and the Jamaican Ministry of Health suggested that there are approximately 33,000 people living with HIV. Of those people infected with HIV, 2/3 are unaware of their status, with the majority of the infections occurring among MSM and commercial sex workers. For Jamaican MSMs, the HIV prevalence rate is about 33%. Excuse me. It was also noted that HIV infections reported clustered predominantly within urban areas such as Kingston and Montego Bay. Within the small island nation in Jamaica, homophobic violence is widespread and sometimes deadly. Mob attacks are common. As a result of the social and cultural rejection of homosexuality, many JMSM live in fear. Some fled their homes due to intimidation and violence. Contributing to the discrimination towards homosexuals is the current antiquated buggery law, or sodomy law. Under current Jamaican law, homosexual sexual behaviors is punishable to a maximum of 10 years in prison at hard labor. Many businesses and property owners often refuse to provide services or housing to MSM. They often cite the island's buggery law as a reason for openly discriminating against MSMs. Oftentimes, condoms and other safer sex barriers are difficult to obtain. They're often placed behind the counter at local supermarkets and grocery stores. With the intersectionality of the social rejection of homosexuality, state-sponsored discrimination, and homophobic violence, many MSMs are at risk, or at increased risk for HIV acquisition. To explore these complex issues, two research purposes were formulated. The first research purpose was to understand the circumstances that place JMSM at risk for HIV. The second purpose was to explore how JMSM navigate their environment to enhance their personal safety. To address these two purposes, a qualitative descriptives design using semi-structured interviews and focus group discussion was employed. Participants were recruited from two locations, both in the Kingston and St. Andrew area. Interviews and focus group discussions were recorded, transcribed, and analyzed using thematic content analysis. A total of 30 individuals met the study requirement and agreed to participate. Of those 30 individuals, 60% identified as gay, 40% as bisexual. For these individuals, the age of first sexual experience ranged from 7 to 24 years. Many of these individuals were from the Kingston, St. Catherine, and St. Andrew area. However, other neighboring parishes were also represented. Majority of the participants were between the ages of 18 and 24. Of the 30 participants, 26 identified with the Christian religion. Educational levels also varied, with half the sample having had a minimum of some college experience. JMSM in this study reported being driven from their homes, forcing them to abandon their belongings, leaving them homeless. This form of discrimination is reinforced by family members, community leaders, police officers, and government officials. Quote, "They treat gay people worse than how they treat dogs. They treat gay people bad. If it comes to it, they will come and tell you that they would light you on fire or light you and burn you in the middle of the road. I know they would do it." Gender expressions that are incongruent with socially and culturally acceptable norms are rejected by the society. Additionally, gender nonconforming or gender variant men from most inner city communities face the most extreme anti-gay violence. These attacks are often unreported or unprosecuted if they were reported. When I was young, I left the country and came to Kingston to live with my mother. During that time, there was an issue with the community. I couldn't tolerate it, so I decided to run away. When I came back and was attacked when I was coming home from school. I guess I was too feminine to live there. So then my mother and siblings told me to cut down on my femininity and man up. I love my makeup, you know. That was hard for me to give up. So someone sent word to my mother that our safety was in jeopardy because I didn't want anything to happen to them or have our house destroyed. I wanted them to live there peacefully, so I left. I was only 15 years old. JMSM reported learning from an early age that homosexuality is unacceptable in the Jamaican society. To be homosexual is considered to be un-Jamaican. Due to the stigma and the discrimination associated with homosexuality, many JMSM developed creative ways of hiding their sexual orientation from persons who may attempt to do them harm. I never knew what was happening to me. I thought it was an experience. I was young and almost a teen. But when I realized how the Jamaican society was at the age of 14, I couldn't express it. I mean, it does not work like that here. And though I had a good relationship with my mother, she would say, I can't be this way. It is not of God. It's ungodly and you'll go to hell. So I made a decision to keep it to myself. The idea of implementing comprehensive sex education has been rejected by the Jamaican government and civil society. Major barriers to implementing comprehensive sex education in secondary schools are directly connected to local and international religious institutions and anti-gay lobby groups whose purpose is to, quote, reject the homosexual agenda, end quote. As a direct result of inadequate sexual education, many JMSM reported receiving information regarding sex from their peers, through personal experience of course, cable television, the internet via pornography, and MSM community workshops, often sponsored by the Ministry of Health. The stuff I know about gay sex, I learned about it hands-on. I didn't use the internet or anything. Mine was through experience. I just fit the puzzle together. When I was 7 years old, me and my cousins would kiss, and then we wondered if our penis could go in other places. So then we experimented, and that was how we knew it could work. The mental health impact of homophobia and discrimination has had a profound effect on the lives of many Jamaican MSM. For some, engaging in self-mutilating behaviors such as cutting was one way of coping with the impact of homophobia. Other JMSM reported preoccupation with suicidal ideation. I tried to kill myself once because I didn't want to deal with this lifestyle anymore. Well, not to kill myself, really just to take the pain away. I don't know if I should be telling you this. I tried it once. I used to cut myself. I was dealing with a bad depression when I was 16. I cut myself when I get stressed or have anxiety. When I don't know what to do, I just cut. For many JMSM, the acquisition of HIV was measured through an immediate and delayed risk assessment. Immediate concerns for these men were being caught in a situation that compromised their personal safety. Their concerns were directly linked to surviving now. Surviving now involved having a place to sleep, food to eat, and a perceived sense of safety. To this end, delayed risk involved not being immediately concerned with HIV during intimate contact with their partners. I guess I've been very lucky. I remember doing it with a person I know. He was a businessman where I was living. I didn't know that he had HIV. I found out after we had sex. I trusted him because he was someone who could do things for me because he's financially stable. I didn't question it. Many of the men in the study reported engaging in undesired sexual activity with other men, sometimes older and with abundant resources. Due to the fact that they can provide them with life's basic necessities, sometimes they had to compromise their bodies further. For example, switching sexual roles from being anal insertive to being anal receptive, if their partners insisted on that as a condition of providing them with basic necessities. He said I have to sleep with him if I wanted to stay in his house. At that point, I had no choice but to sleep with him. It was at a time in my life where I had nowhere to stay, and that was what I had to do in order to have a roof over my head. It made me feel small in myself. I guess that's just a part of being gay. Jamaican MSM reported accessing their health care from various aspects of the healthcare sector in Jamaica. For those with limited resources, they reported discrimination from other patrons while in the waiting rooms in rooms of public health clinics and from some healthcare workers. To combat the issue of harassment and discrimination, many MSMs develop sort of a buddy system with an MSM-friendly provider. So if they've seen someone who is friendly to MSMs, they will actually refer those persons to their that person to their friends. As mentioned previously, in the study reported MSM in the study reported several strategies that they use to protect themselves from homophobic violence and discrimination. Some of these strategies include hiding their appearance or changing their appearance when out in public. In most cases, I would just try to act masculine in public. I create an edgy version of myself in order and around others who I know strictly are safe or who are against homosexuals. So basically, I just act tough or toughen up myself more than the real me. I'm never real unless I'm around good friends. I dress more clean, nothing that draws too much attention to anyone, just average. And then end in, as clinicians, policymakers, advocates, and allies, we must immediately address the issue that place MSM at risk for HIV and other negative health complications. To achieve this, we must advocate for the removal of structural barriers, including legal barriers that inhibit access to life-saving prevention services. The Ministry of Health, private sector partners, and other key stakeholders must ensure the sensitization to and education of more culturally competent healthcare providers around issues related to gender, gender identity, gender expression, sexuality, and sexual orientation. Along with the removal of structural barriers and proper education of culturally competent healthcare workers, the government must improve public health facilities so that they are accessible to and welcome to all, regardless of one's sexual orientation. Finally, we as clinicians or persons who provide care to vulnerable populations must engage all of our patients with the basic human dignity and respect that they deserve. Thank you.